Okay, so the tutorial is really on ARDS, and it's an abbreviated kind of presentation to the sort of ARDS discussion at length, because that's quite a larger presentation with a lot of pathophysiology of ARDS, which I think we won't have the time to go into, but I'm really going to focus on how one can tailor ventilation to the patient in front of you and at the bedside, and how we can hopefully improve things in terms of gaseous exchange with these patients who are often very, very difficult to manage. So the consensus guidelines and the sort of updated recommendations on managing this disease was published recently in towards the end of 2023. The American guidelines was published, and then early in 2024, the European Society also published their updated guidelines, and the two societies work independently, but they focused on a lot of similar issues in terms of what's changed and what needs to be updated in the guidelines. The Europeans focused a lot on the definition, talked a lot about how we can phenotype patients with ARDS, because we seem to put all these patients under one umbrella, and unfortunately there are different phenotypes when it comes to patients presenting with this syndrome, which we call ARDS, because some patients have a lot of inflammation that we see happening in the lungs particularly, and they might respond to different strategies. And in other patients, we often see there's quite what's called a hypo-inflammatory state. So these phenotypes can also be patients who present with much less inflammation in the lung, and they often not very responsive to all the strategies that we tend to recommend for improving their oxygenation, and often these patients have a much worse outcome. So it's unfortunately not very clear from what tests we do at the bedside to determine which phenotype these patients belong to, but just to appreciate that not all patients will respond to the same strategies that's been recommended to treat the ARDS syndrome. And then I think we're going to talk a lot about what's new in terms of how to ventilate these patients, or how to assess what strategy to use to ventilate these patients. So this is the American guidelines that came up with this very nice table or graphic, which looks at what's really come out of the consensus guidelines as the main points to take home. What has really been now discarded as recommendations to manage these patients is to do these very old-fashioned, prolonged recruitment maneuvers that we all love to still perform, but it's really not recommended because it causes worsening mortality, particularly because these patients can be hemodynamically unstable and they can arrest and have major adverse cardiovascular events if we use these prolonged, old-fashioned recruitment maneuvers. And we'll talk a bit about what the difference is with old-fashioned recruitment versus what we would do currently when it comes to PEEP titration. High-frequency oscillation is a mode of ventilation that was thought to be beneficial in patients with ARDS because it limited our tidal volumes, and it's mainly been used in pediatrics, but I think the evidence for the use in peds is also not very strong, but there was a very large randomized controlled trial showing that high frequency oscillation in ARDS was actually associated with with worse out with mortality. So what's come in favor for managing these patients? There's a very strong recommendation to paralyze these patients when they have severe disease. So you can see there when the CF ratio starts to drop below 100, we need to consider neuromuscular blockade. We won't talk about VV ECMO much, but obviously in a center where you have access to ECMO, this is also the group of patients where we need to think about ECMO earlier rather than later. And then the Americans came up with a very strong, maybe it's seen as a conditional recommendation, but it was quite a highly supported recommendation for systemic corticosteroids. And I think this came from the big trial that was published looking at community-acquired pneumonia, showing the benefits of using adjunctive steroids. So steroids plus antibiotics in patients with community-acquired pneumonia, especially if they were on a ventilator and they developed what could be defined as ARDS. Then high peaks, I think that comes with a lot of conditions because we talked about these phenotypes, and I think high peeps is not a rule that should be applied for every patient. I think that recommendation is something that we can discuss further, and I'll tell you what we do in terms of setting peeps. And then one of the most sort of strongly favored recommendations was prone positioning. And I must say this is a very cost-effective, easy, when I say easy, it does take a lot of manpower, but it doesn't require major fancy resources. But prone positioning is definitely associated with benefit and with improvement in your gaseous exchange. So it should be considered almost in any patient with ARDS where you're starting to hypoxemia with increasing ventilatory support. And then we'll talk a bit about the old standard sort of lung protective ventilatory strategies. That hasn't changed because I think that's been well in the evidence that's out there. This is the European guidelines, and I just put it up there to show you that they focus on the same interventions: corticosteroids, VV ECMO, neuromuscular blockers, high peeps. But there were some precautions that were mentioned because not all of these recommendations are without their own inherent harms or risks. And then there were very nice practical considerations when it comes to, how do we decide when to use neuromuscular blockers? How do we practically administer and how long for do we use these neuromuscular blockers, high peeps, how to assess the effects of the high peeps, etc., etc. So a lot of very practical recommendations. And I've just put this slide in because we always talk about high flow. And just to say that high flow doesn't really come with a lot of high grade evidence in terms of showing benefit. It's certainly one of those things to think about when you've got a patient with acute hypoxemic respiratory failure. And I think high flow became quite popular during COVID, and there was a sort of a highly separate recommendation for patients with COVID pneumonia. And I think that was really because once patients got intubated with COVID, their outcomes were a lot worse. So the high flow does have some role to play, probably in mild disease and in patients who need supplemental oxygen. And it's much better to use high flow than to put them onto a face mask if they're needing prolonged periods of oxygen therapy, because it's humidified and the high flow does provide some level of support. And then there was some favorable recommendations for the use of non-invasive ventilation, mainly in patients with COPD, and then patients who had pulmonary edema, who needed some positive pressure. So that's kind of where the recommendations for high flow should remain. We shouldn't be using high flow for patients with severe disease, patients with pneumonia who are hypoxemic. I think those patients should rather be intubated and managed with mechanical support. So the management of ARDS can be summarized in this very nice graphic, which I must say contains all the interventions that have been studied and trialed and shown to either be associated with improved outcomes or improvement in oxygenation. Not all of them have been associated with survival benefits, but we know that ARDS is not a diagnosis that is associated, let's say it's not a diagnosis, it's just a manifestation of the respiratory component of a systemic disease. So we need to treat the underlying disease process in order to change mortality. But as you can see, the interventions are not new to all of us. It's really same strategies that were described in the consensus guidelines: prone positioning, low tidal volume. I like this term individualized PEEP because high PEEP's not for everybody. Can actually be from low to high. Steroids, neuromuscular blockade. I'm going to talk a bit about mechanical power because that's really what we need to talk about in terms of how our ventilator is set and what the impact is in terms of causing lung injury due to harmful or not using lung protective settings. And then don't forget about fluid management because that's quite important, particularly with a patient who's severely hypoxemic. So this was just the phenotyping concept. As I said, the group of case mix of patients with ARDS is very heterogeneous. So we have patients with a lot of inflammation. You can see that they have a higher mortality, and the hyperinflammatory group have high levels of cytokines. They looked at various other biomarkers that can subgroup these patients into a specific phenotype. And then you can see that patients with low levels of inflammatory mediators are divided into a hypo-inflammatory group. And then to really understand that this is not a one-size-fits-all type of approach in managing these patients, because these different phenotypes respond differently to all those interventions that are described in the previous slide. So this might be a concept that we don't often talk about, but it's certainly what we should be viewing as the current assessment or description of how safe and how protective our ventilator settings are. And it's this concept of mechanical power, and why it's called that is really to take the effects of mechanical ventilation back to its sort of physical principles and to describe what the ventilator does to the lungs in terms of physical forces. Because the ventilator is purely a device that exerts pressure or a volume onto the lungs, and that is a force that has harmful effects on the lungs if it's done inappropriately or if it's not set correctly. So these mechanical or engineering concepts are encompassed in this sort of very complicated looking equation called the power equation, but it really involves all of those very well-known principles of lung protective ventilation. And really what makes the mechanical power equation more useful is that it takes into account all the different settings on the ventilator that we sometimes don't pay enough attention to in terms of their impact on lung injury. And when we sort of break down this mechanical power equation into its bare principles, it's really just the energy required to move gas into the lung, to keep the lung, to distend the lung, so to overcome the compliance, and that is sort of essentially the driving pressure, and then the amount of energy required to keep the lung open. And this is where PEEP can become a more important component, because PEEP does transfer some degree of energy to the lung, or the PEEP setting has some impact on the amount of static energy that's transferred to the lung. And if it's excessive, it can be it can be harmful. But the most important part of this equation, and it's what's not included in any of the other recommendations when we think about lung protective ventilation, is that this transfer of energy across the lung is exerted by the ventilator over a frequency or a breath rate or a number of breaths per minute. And that's what I think has changed in terms of our understanding of lung injury, because the faster we ventilate patients, the higher the risk of this harmful force that's delivered to the lung. The risk of lung injury increases the faster or the higher the frequency at which we're delivering this force to the lung is. So we never really focus a lot on breath rate, but when we look at the power equation, breath rate is very, very useful. Not useful, it's actually essential in terms of assessing how safe our ventilator settings are. And if you thought that equation is very complex, this is a very simplified way to do the power equation. And in time to come, over the next year or two, I think we are going to be talking more about mechanical power as a number, rather than looking at tidal volumes of 6 moles per kg or driving pressures of less than 15, etc. We're going to say mechanical power of less than X, because if you think about the units of mechanical power, it's in joules per minute, and it's very similar in terms of the actual number to the driving pressure limits, because as you can see, there's been some data looking at mechanical power and mortality in patients with ARDS. And you can see that as mechanical power increases above 20, some will say above 18, which is very much like the driving pressure concept, we start to see greater risk for mortality. So I've got an app on my phone where I can work out the mechanical power by punching in the tidal volume, the respiratory rate, the peak pressure, and the driving pressure, and it spits out a number. And we really want to aim for a mechanical power of ideally less than 18, about 16 if you wanted to be lung protective. But once it's above 20, we start to see increased potential for harm. And really the focus is, once you have calculated your mechanical power, you really want to then try and look at strategies or settings on the ventilator that you can manipulate to come down on mechanical power. And one of the easiest ways to do that is to look at your respiratory rate, because sometimes we're ventilating patients at a set rate for no good reason, just because we like that number. And we might be chasing the wrong endpoint, especially if we're looking at it in terms of CO2. But I'll talk a bit about CO2 later. So when we apply excessive power or we apply excessive force to the lung during mechanical ventilation, we can induce what is almost similar to a form of ARDS to the lung. So we can worsen outcome and we can worsen patients' gaseous exchange with added injury from mechanical ventilation. And we know that when we ventilate patients with either injurious or ventilator settings that are not lung protective, we see worse outcomes and possibly increased mortality. So ventilator-induced lung injury is a real risk, and it is a real complication of poor lung mechanical ventilatory settings. So this was just a very nice paper that looked at what happens when we do see patients coming into the ICU, particularly after they've been in theater. And this is the typical patient who doesn't have ARDS, but where we might be setting the ventilator inappropriately and worsening their or increasing their mechanical power and worsening their risks of ventilator-induced lung injury. So it looked at adjustments of ventilator parameters during the operating room to the ICU transfer and transition period. And they also looked at 28-day mortality, although I must say that this study was not powered for mortality in terms of statistical significance. So they looked at settings that would change, and you can see that the two settings that would change most frequently was that the respiratory rate was increased quite dramatically. This is sort of a intraoperative setting of 12 breaths per minute, which is kind of the standard anesthetic anesthetist setting when they turn on the ventilator. And then the patient comes to ICU, and for some reason in this study, respiratory rate was increased up to, sometimes 18, 20 breaths per minute. The dotted line is the median respiratory rate. And then, like we all do in ICU, we're very, very focused on non-protective ventilation. So we then decrease the tidal volume, and you can see that often patients are ventilated in theater with tidal volumes of greater than 8 mol per kg. And in ICU, we're very focused on making sure that patients are ventilated with lung protective strategies. So two opposing sort of setting changes. But let's look at what happens to these patients in terms of the impact on their mechanical power. And what you can see is, obviously, when you increase the respiratory rate, you increase mechanical power quite dramatically. Okay, and this was the blue, which was the change in mechanical power in that transition from being in theater to ICU. And what was quite interesting was that when they looked at all the changes that were made to the ventilator, the one that was associated with the most impact in terms of increasing mechanical power, but also potentially worsening outcome, was the increase in respiratory rate. And I want to emphasize this change in respiratory rate because we often do that for no good reason other than we think that the patient should be ventilated at a respiratory rate of 20 or 18 breaths per minute. Okay. And we'll start to see a lot more evidence for what the effects are of high respiratory rate is on outcome and on patients' ARDS progression or just the course of their stay in ICU while on mechanical ventilation, because respiratory rate can have a number of injurious effects both on the lung itself but also on the diaphragm. It leads to a lot of ineffective efforts during positive pressure ventilation. And what we ultimately see is that we can have increases in ventilator-induced lung injury as a result of high respiratory rate. Now, often, or you might say to me, well, what about the patient just taking more spontaneous breaths and your ventilator is set at 12 breaths per minute, so that should be fine. And I think this concept is been well shown, particularly in patients who have severe ARDS. So these are patients with PF ratios of less than 150. And what the impact is of breathing spontaneously while being mechanically ventilated. And you can see that when patients are breathing spontaneously and have severe disease, particularly with disease being distributed to the sort of posterior or the dependent parts of the lung, we see that these patients who are now breathing intermittently but spontaneously and being mechanically ventilated, we see that there are areas of lung or areas in the lung that are exposed to quite significant negative interpleural pressure. And this is due to vigorous sort of diaphragmatic excursion, because these are areas of lung that are quite poorly compliant, so they're very consolidated. The patient is sucking very hard on the ventilator to try and draw gas into that dependent part of the lung. And what happens is that these large negative pleural pressures leads to much higher what's called transpleural pressures or transpulmonary pressures, because the driving pressure required to distend this very, very consolidated part of the lung is much higher in that diseased area of lung. So that area of lung is exposed to more inflammation and subsequently worsening risks of lung injury. Okay, and this concept has been given a name. It's called patient self-inflicted lung injury, which I think is a terrible name, because it's not like the patient, inflicted on themselves. It's just that because they're allowed to breathe spontaneously, they're so hypoxemic, they have high CO2s, they have a higher respiratory drive, they're going to be working much harder to try and address their BQ mismatch, and this leads to more lung inflammation. So the question really is, how do we prevent this? And I think this illustration here was mainly to highlight how PEEP in this setting can be protective, because if we start to apply higher or increased positive pressure, it decreases that interpleural pressure, which then splints those alveoli and creates a smaller or decreases the gradient across those areas of lung so that the patient's not sucking as hard and creating these large transpulmonary pressure gradients. That's the one way to mitigate this problem. The other one is to paralyze patients or to sedate them well enough so that they're not breathing spontaneously. They're not actually fighting the ventilator and not exposing their consolidated areas of lung to these large transpleural pressures. So the diaphragm is essentially not being vigorously exercised as a patient who's not sedated or paralyzed. And then obviously the last strategy that one can try to improve this situation is to prone patients, because proning just redistributes this pattern of lung inflammation or spread of the exudate in the lung, so that we don't see these sort of very consolidated, dependent areas of lung like you would in a supine position. So, saying all of that, there's been very nice guidelines published on how to manage muscle relaxants, but also sedation and analgesia in the ICU. And really the risks have been very nicely sort of, illustrated in this algorithm, where one needs to start to adjust your sedation and consider neuromuscular blockers based on your PF ratio. Okay? And once your PF ratio is less than 150, okay, you need to think about adjusting ventilator settings, titrating sedation, analgesia, etc. Making sure that you consider proning patients after you've ensured that we have lung protective ventilatory settings, and then to also consider neuromuscular blocking. Okay, there are also very clear recommendations for when we shouldn't paralyze patients, and we really don't want to paralyze patients unnecessarily, because that is associated with a whole host of other complications related to muscle relaxant. So what we really want to do is we want to be guided by the PF ratio, and first of all, optimize sedation and ventilator settings, looking at lung protective settings and seeing whether we can achieve that. And if you can't achieve that, then to consider neuromuscular blocking. So what about PEEP? I think this is always a very hotly debated topic, because we all seem to have our own strategy or our own ideas about how to set PEEP. And unfortunately, it's very much sort of all over the place in terms of what PEEP to set. And I think one of the more updated, or one of the more sort of recent recommendations to set PEEP has been as yet not included in these guidelines that I have mentioned, but there's been a lot of recent data now looking at the value of electrical impedance tomography. And that might be a new concept or a new monitoring tool that is something that you're not familiar with. And I must say, we just used the EIT this morning on a patient where we weren't sure what PEEP setting to use. Patient with severe ARDS, very difficult to ventilate, quite hypoxemic. And that's really when you want to consider EIT. So what is EIT? Well, it's a series of electrodes, electrical current that is placed across the chest wall. It's a single belt with 16 electrodes that goes circumferentially around the chest wall. And what these electrodes do is that they measure the impedance across the chest wall between all of these 16 electrodes. And when we talk about impedance, it's essentially the resistance to current flow. And impedance, the changes of impedance in terms of lung physiology or respiratory physiology correlates very well with changes in lung volume. And what do I mean by that? Well, essentially, when we put this impedance belt monitor on the patient, we then get what you could almost describe as a single slice, like a CT scan of the lung, but in real time, but also on a breath-to-breath basis. So essentially what we're seeing when we're looking at the EIT is we're looking at where gaseous or where ventilation is distributed in the lung. And obviously that would correlate with gaseous exchange. I'm not going to go into EIT in a lot of detail. I'm happy to talk about it if we have any questions about it. But essentially, this slide just shows you what the distribution is of ventilation. So the blue indicates changes in lung volume. Okay. And essentially, as we go from blue to white, we see that blue is associated with the biggest change in lung volume and white associated with the least change. And you can see that this is a sort of a patient who's supine, so that's posterior, that's anterior. We often see a bit of dropout on the left side because that's where the mediastinum tends to, and the left heart tends to impair lung expansion. And these changes, as you can see here, over a series of changes in PEEP show different tidal or regional ventilation. The EIT also has the ability to look at changes in compliance. Okay? And really that's done by looking at the changes in pressure with changes in volume. And the changes in compliance is represented in orange, and where you see the dark orange areas. So this is a patient who has had a PEEP of 18 set, and you can see that at a high PEEP, especially in the anterior, non-dependent part of the lung, we see compliance being lost as we start to over-PEEP this lung and over-distend the very sort of compliant part, which is typically sort of the anterior or the non-dependent part of the lung. As we come down with PEEP, we start to see much less compliance loss. But if we start to drop the PEEP to 12, 10, we start to see compliance loss now in the posterior or the dependent parts of the lung, which is now represented by these white shaded areas. So very dynamic. It certainly gives us real-time representation of changes in lung volume and also changes in compliance. And I think this is really what EIT tries to achieve, looking across the entire lung, which is, I suppose, not always the case because we sometimes have regional differences in ventilation and distribution of gas flow, but it's trying to find the sweet spot between preventing collapse and not causing over distension. So it's really trying to find the optimal compliance of the lung with your PEEP setting where you don't have excessive over distension, but you've decreased your risks, or let's say you've recruited areas of lung that has previously been collapsed. And the data shows that when you guess the PEEP setting that you have to dial in for the patient based on either the X-ray, either the condition, or just looking at maybe the compliance on the ventilator, half of the time your PEEP setting is probably close to what EIT will show you, but the other half of the time it is completely incorrect. And we've seen patients who have severe ARDS where we have to come down with the PEEP to 5 because any PEEP setting higher than that was associated with compliance loss. And the only way to tell what the optimal PEEP is to perform a EIT assessment on the patient using the EIT monitor. Just to say that we know high PEEPs can be harmful to the lung in more ways than one. It causes hemodynamic disturbances because of the increased intrathoracic pressure and decrease on your venous return, etc. But overdistension is a big problem when it comes to lung injury. And that's where the mechanical power equation sort of comes back into play, because that high PEEPs can cause lung injury by causing overdistension. The final thing to say is that we can't really talk about ARDS without looking at right ventricular dysfunction, because we know that in patients with severe hypoxemia, the RV doesn't tolerate the severe changes in afterload of the right ventricle. So we see high pulmonary pressures because of increased pulmonary vascular resistance. As the RV doesn't tolerate high pressures, it starts to dilate, as you can see on the right here, and it starts to impact on LV filling. So this septum starts to move paradoxically into the left ventricle, and we see essentially cor pulmonale acute cor pulmonale as a result of worsening ARDS. And these patients present with low cardiac output, and the inherent problem here is that we want to always try and improve things with giving patients more fluid, and that might worsen their ARDS. We certainly need to try and fix the hypoxemia or the hypercapnia and try and support the right ventricle in order to improve our hemodynamics. This is really where ECMO has a very strong role to play, or a very strong position in terms of trying to address this phenomenon of RV dysfunction. And obviously in the centers that can offer ECMO, what we would certainly evaluate as being candidacy for ECMO is, first of all, are we able to ventilate these patients with lung protective ventilatory settings and not induce high mechanical power forces to the lung? If we can't do that, we need to think about ECMO. And if RV is failing, certainly need to consider ECMO. And the configuration to try and offload the right ventricle has been kind of revolutionized here, and we even have catheters that can be placed all the way into the pulmonary arteries themselves offload this right ventricle and to improve right ventricular dysfunction. I'm going to say just a few words on hypoxia, because we know that we tend to see more lung injury with higher PO2s. So really with ARDS, we want to target conservative or PO2 targets of no more than 8 kilopascals, and anything above 10, 12 kilopascals can be associated with more reactive oxygen species being released and more lung injury. We know that the lung injury is on a multiple of mechanisms, but hyperoxia is definitely to be avoided in any patient, but particularly patients with ARDS. And when we look at subgroups of patients who might, we think, benefit from higher PO2s, there's really no subgroup of patients that needs a alteration in their PO2 targets. 8 is adequate for patients with stroke, with traumatic brain injury, sepsis, cardiac, etc., etc. So no real subgroup where we need to make any exceptions to this rule. And then what about CO2? As I said earlier, we often try to increase the respiratory rate because we want to normalize the CO2, but CO2 is not a big problem, particularly if the pH has adjusted and we don't see more respiratory acidosis as a consequence of high CO2. So often we want to fiddle with the ventilator when the CO2 is slightly elevated. Don't or try to resist that temptation. Rather look at the pH, and unless the pH starts to drift below 7.2, one shouldn't target a normal CO2. And we can see that the role of permissive hypercapnia on mortality was actually associated with no harm, and there's some data, particularly when you just allow the CO2 to drift up, is associated with mortality benefits. So normalizing the CO2 has really got no benefit at all, and we should certainly allow the CO2 to drift and not to target increasing our, or not to normalize the CO2 by increasing our ventilatory support, because we're trading that with possibly worsening lung injury. This is, I think, one of the last slides. It was a very nice study because the most common question that we tend to get, particularly in other hospitals, is, well, what mode of ventilation is best for patients with ARDS? And unfortunately, there is no perfect mode, no perfect ventilator setting for patients with ARDS. It has to be individualized to the patient in front of you. And this was a very large, probably the largest study looking at mode of ventilation in patients with ARDS. And you can see that the outcomes were very similar. It was an assist control in a volume controlled mode versus patients in a pressure control group who were allowed to receive some form of pressure support if they were breathing spontaneously. It wasn't very clear how severe these patients' ARDS were. I think they were, once they met the criteria, they were recruited into the study. The mortality is very high. As you can see, 35% on average is a significantly high mortality, but that's the described mortality with ARDS in ICU. What was interesting was that patients in the pressure control group needed less adjunctive therapy for hypoxemia. So pressure control ventilation certainly provides, I think, better gas flow, more reliable gas flow, particularly in patients with stiff lungs, and they needed less sort of adjunctive therapy, so less proning, less high peeps, less recruitment, etc., than the patients in the volume control group. And then if you looked at sort of anything else that might separate these patients in terms of differences in management, when we use these two modes of ventilation, there was less sedation required in the patients who were in the pressure control group. So they had much better patient-ventilator synchrony, and that's probably because with pressure support ventilation added to the pressure control settings, it provided patients with much better patient ventilator synchrony. So this is the only evidence. It was a study published towards the end of 2024, and it certainly, answers the question that we don't really have specific mode that's tailored for patients with ARDS. So we need to move away from sort of our old thinking in terms of lung protective ventilation. We need to think in terms of mechanical power now. And I think mechanical power is really how we should express our ventilator settings, and we should all be sort of well versed in terms of what power settings are harmful or what value in terms of mechanical power we need to be careful of. And we need to individualize that for each patient. So we need to construct these dose response curves for the changes in compliance. And I think we can do that, particularly when we're thinking about setting PEEP with using EIT. And then, as I said, this was called personalized ventilation. So, we got to think about tidal volume, driving pressure, transpulmonary pressure, especially when patients are breathing spontaneously, mechanical power. Does this patient need a PEEP type of recruitment assessment? Do we need to do anything more than plain form chest X-rays? And I think electrical impedance is very, very promising, and not to forget about those different phenotypes. Okay, so I think that's really the end of my talk. I think I have maybe given you a lot of food for thought, I hope. But this was just a very interesting paper looking at what the future holds in terms of directives and future research opportunities in ARDS. And it's really tailored at individualizing our care for patients with ARDS.